Welcome to the Mayo Clinic Cardiovascular Masterclass.
I'd like to speak to you today about pacemakers, ICDs, and cardiac resynchronization therapy. I have no disclosures. Let's list the indications for ICD implantation for primary prevention and select appropriate patients for this intervention. You've already heard from Dr. McLeod about secondary prevention ICD therapy. I'm focusing on primary prevention. Secondary sudden cardiac death prevention is defined as sudden cardiac death survivors, patients with documented sustained VT or VF, or unexplained syncope with inducible VT at electrophysiologic study. Clearly, these patients have a high risk for recurrence, and ICD is beneficial, and Dr. McLeod has covered that area. So I'm going to focus on primary prevention of sudden cardiac death, which would be defined as follows. Patients with structural or electrical heart disease associated with an increased risk of sudden cardiac death, but they've not had an event yet, so no prior cardiac arrest, no sustained VT, or unexplained syncope. I would like to emphasize that sudden cardiac death risk, and as a corollary, the likely benefit of an ICD, is most rigorously established in ischemic and non-ischemic cardiomyopathy, meaning depressed left ventricular systolic function. So as we talk about ischemic and non-ischemic cardiomyopathy, let's just briefly cover over time the landmark trials that have allowed for the current criteria for ICD therapy. So the story started with the Madit and Mush trials, where patients with ischemic cardiomyopathy alone, EF of less than 35 or 40% respectively, who had non-sustained VT and were inducible in the EP lab. They were shown to benefit in terms of mortality from an ICD. The next step in the evolution of this story was Madit 2, where patients with ischemic cardiomyopathy and quite advanced systolic dysfunction, EF less than 30%, but no other prerequisites, were randomized to receive an ICD, and the ICD was life-prolonging. Then came SCUD-HEFT, very important trial for the non-ischemic cardiomyopathies, in which patients with both ischemic and non-ischemic cardiomyopathy and EF less than 35% and class 2 to 3 congestive heart failure were randomized to receive or not receive an ICD. And in this group of patients, again, the ICD was life-prolonging. The DYNAMITE and IRIS trials were post-MI trials, where an ICD was placed within 40 days of myocardial infarction in patients with a large infarct and certain ECG markers of risk, which I'll cover in a little bit. And importantly and surprisingly, there was no ICD mortality benefit in this group of patients. Lastly, let's remember that Medicare has some remarks for our learning. CMS has said that you can implant an ICD greater than 40 days post-MI. However, if that post-MI patient was revascularized percutaneously or surgically, or if you're dealing with any cardiomyopathy that is not yet on guideline-driven medical therapy, you have to wait 3 months. So acute MI, EF of 30%, receive PCI acutely, you don't give them an ICD at 40 days. You wait 3 months and reassess left ventricular function. That's not trial-based, that's a directive from Medicare, picked up, of course, by other third-party payers. So how then would we summarize the primary prevention ICD indications in patients with systolic dysfunction? Well, if you have an EF less than 35%, you're New York Heart Association class 2 or 3, that's all you need, class 1 indication for an ICD. Your EF is less than 30%, your New York Heart Association class 1, asymptomatic, and it's an ischemic cardiomyopathy, you can offer an ICD. If the patient has an EF less than 35%, is asymptomatic, and it's a non-ischemic cardiomyopathy, that's a class 2B, relatively weak indication for ICD. And finally, in that 35 to 40% ejection fraction range, where you have non-sustained VT, ischemic cardiomyopathy, and it doesn't matter what heart failure class. If they have inducible VT in the EP laboratory, you can justify ICD implantation. Remember that New York Heart Association class 4 heart failure, there is no standalone indication for ICD therapy. These patients have to be stabilized and rendered class 3 before you can think of an ICD. Remember, after myocardial infarction, you have to wait 40 days if they're not revascularized. If they are revascularized or you're dealing with any cardiomyopathy that is not on optimal medical therapy, you need to wait 3 months. 3 months after PCI or CABG, 3 months after initiation of optimal medical therapy. Now, Dr. Amann has spoken previously about hypertrophic cardiomyopathy, an area where there are clear recommendations for ICD therapy, but they're much less rigorously evidence-based. And this diagram summarizes the approach to deciding whether to offer an ICD to these patients. You need at least one major risk factor. So if the patient has had cardiac arrest or sustained VT, that's a secondary prevention context. They need an ICD. But if we're talking about primary prevention, then you need to either have a family history of sudden death in a first-degree relative, left ventricular wall thickness greater than 30 millimeters, or a recent history of unexplained syncope. And if you have one of those, an ICD is reasonable, class 2A. If they don't have these features, but they have non-sustained VT on ambulatory monitoring or an abnormal blood pressure response to treadmill exercise, and you have some other ancillary observations, LVOT obstruction, gadolinium enhancement of the myocardium on MRI, apical aneurysm, or what is perceived to be a malignant mutation, an ICD can be justified. And you should not offer an ICD if none of those clinical features are present. A couple other disorders I would like to comment on in terms of primary prevention ICD therapy. Arrhythmogenic right ventricular cardiomyopathy. It's a class 2A indication for ICD if you have greater than or equal to one risk factor, and those risk factors include young age, male gender, extensive RV involvement by their ARVD, left ventricular involvement, non-sustained VT, inducible VT, or what is perceived to be a high-risk genotype. What about long QT syndrome? Let's remember Dr. Ackerman's remarks. It would take a very unusual set of circumstances for you to be asked to tell a long QT patient that they need a defibrillator as primary prevention. That's the key message. Most of the time, these patients are going to be treated medically, typically with a beta blocker. So the only circumstance in which you're going to think about primary prevention ICD therapy and long QT syndrome, and I would be surprised if this scenario were put before you, would be the patient who has beta blocker noncompliance or intolerance, or someone perceived to have a high-risk gene for sudden cardiac death, and then it would be class 2B. The guidelines list a variety of other clinical scenarios for which primary prevention ICD therapy can be offered. They include the patient awaiting cardiac transplantation, the Brugada patient with inducible VF, still a controversial field, the patient with cardiac sarcoidosis, giant cell myocarditis, Chagas disease, familial cardiomyopathy associated with sudden cardiac death, or left ventricular non-compaction. So in summary, I've covered the following points. Remember that primary prevention ICD therapy has been most precisely established in ischemic and non-ischemic cardiomyopathy based on EF and functional class. Remember that we have to wait 40 days after acute myocardial infarction in the absence of revascularization and 3 months after revascularization, or for a baseline cardiomyopathy, 3 months of goal-directed medical therapy. In other disorders, separate from ischemic and non-ischemic cardiomyopathy, there are broad primary prevention ICD criteria in the guidelines, specifically for hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, and miscellaneous other diseases, but there's limited data.
We hope you enjoyed this presentation.